purpose. Often, often we become reluctant because we are poor in strategic planning of weaning up either endotracheal tube or tracheostomy tube. If you won't accept the patient stay for a long period in the ICU, which gives rise to hospital acquired infection or ICU acquired infection, which deteriorate the patient. So, for all of us, for all students, must know the basic planning for weaning a endotracheal tube or tracheostomy tube in rehab setup, so that we'll not reluctant and we can very well manage the patient in our ward when a patient come with endotracheal tube. So, for regarding this topic, we have with us today Dr. Gourav Sannyasi. He is the consultant in Department of Neurorehabilitation at Institute of Neuroscience, Kolkata. He has completed his post-graduation from CMC Vellore, and also he has done postdoctoral fellowship in neurorehabilitation from NIMHANS, Bangalore. He has special interest in innovation in neurorehabilitation. He has already presented a talk, Bone Health and Spinal Cord Injury, most probably in the month of February. So he is one of the expert in neurorehabilitation and management in ICU. Let us listen from Dr. Gourav Sannyasi regarding strategic planning in weaning of endotracheal tube and tracheostomy tube in rehab setting. Welcome, Dr. Gourav Sannyasi, for your presentation. Thank you. Over to you.
Yeah. Thank you, sir, for your kind introduction. So, just before starting the talk, I'll just say that this topic is mostly majority of us. We see patients both in the general ward and ICU and HDU. This is the mainly the patients who are in HDU setup and ICU setup, and how you gradually wean off and take him under you in itself in HDU and gradually move him to step down or general bed. So, what is weaning? So, weaning is a process of withdrawing the mechanical ventilatory support and transferring the work of breathing from the ventilator to the patients. So, whenever a patient with either head injury or stroke or even spinal cord injury patient is coming, the main purpose is to just protect the airway. And if they have a low GCS, GCS is less than 7, saturation is falling, then you have to ventilate the patient. So you have to put the endotracheal tube and then put him on ventilation just to reduce the work of breathing and also maintain the airway. For the stroke patient, the other purpose is like if the patient has a infratentorial stroke or brainstem stroke, there will be a central loss of respiratory drive. In spinal cord injury patient, the reason is that the airway is intact, but the respiratory muscles are weak. High level cervical spinal cord injury, they will have like diaphragmatic palsy because of the phrenic nerve injury. So muscles are not working. So you have to give pressure to inspiratory pressure and expiratory pressure to maintain the breathing. So what are the factors associated with successful weaning? So we have to see the patients as a whole. First, what is the patient's underlying condition, whether that has improved. Suppose a patient with stroke who was ventilated and probably he had midline shift with a hemorrhagic transformation. Patient underwent craniotomy. Gradually, patient is improving. He's becoming more alert. So that's the thing, that underlying condition of the patient is improving or not. That first thing we have to assess. And then the patient's general condition. General condition means patient's cardiovascular status, whether the patient's respiratory rate, cardiovascular, the heart rate, everything is fine or normal, or it's coming towards normal. If the patient has any potential airway problems, that have to be identified. So airway problems that can happen from the ventilator to directly to the alveoli. If the patient has an ARDS or any kind of lung injury during the trauma. Suppose a patient has spinal cord injury, most of the patients will come with a rib fracture landing up with a pneumothorax. So they will have lung contusion. So what is the lung airway problem? That also you have to assess. And last is the breathing adequate. So the respiratory rate and the respiratory pattern you have to see. So coming to the what is the airway problems. So airway, particularly the laryngeal airway. So mostly while inserting the endotracheal tube in the emergency setup, there may be a traumatic endotracheal tube and difficult endotracheal intubation. So that sometimes lead to if there is a history of self-extubation, that can cause any laryngeal edema, or sometimes the laryngeal, if the cough or the cough of the tracheal tube or the endotracheal tube is inflated for long duration, there also can be laryngeal edema. So before giving the patient a weaning trial, we have to see whether the patient has any kind of history of traumatic or difficult intubation, history of self extubation or intubation for prolonged periods. There's one concept here, cough leak test. Cough leak test means that ability to breathe around a deflated endotracheal tube, or the presence of a cough leak more than 130 ml during the volume cycle ventilation. So basically, your endotracheal tube is there through larynx, and the cough is inflated. So the main airway is the endotracheal tube. So while giving the patient's weaning, whether he is eligible for weaning or not, we have to deflate the endotracheal tube cough, and we have to see what is the breathing. If the patient, there is a cough leak, once if the air around the cough is present, which is more than 130 ml, that can be seen in the ventilator itself, or you can auscultate it also over the trachea. So if that is present, that means there is no laryngeal edema. So despite uh, deflating the cough, patient is still able to breathe. So that is a cough leak test is positive. That's a sign that you can wean off the patients from the endotracheal tube. Now, coming to the general preconditions for commencement of weaning. So, what I told, reversal of primary problem, which requiring the ventilation. Now, how is the patient's clinical condition, whether he is awake? Because most of the time, while putting the patient on ventilator, we need to paralyze the patients, we need to sedate the patients, because ventilator is giving breath. Patient is also trying to breathe. So, there will be always a difficulty in synchronization of breathing. So, because of that, to put the patient on ventilator, we have to keep the patient either paralyzed, or you have to sedate the patients. So we have to see whether the patient is awake or responsive, whether the sedation is reduced or not. Now, always we need a good analgesia, and we have to reduce or minimal the dose of inotropic support if the patient is on NORF or NORAD, whether that support, because otherwise there will be myocardial ischemia if you reduce the ventilation at that point of time. And the bowel movement also is important, because most of the patient with a spinal cord injury, they will land up into ileus. So that will cause abdominal distension. Now, abdominal distension increase, it pushes the diaphragm up. That will increase the intrathoracic pressure, and that leads to decrease your venous return, because intrathoracic pressure increase, superior vena cava, inferior vena cava, they are all complex. Venous return will reduce. So if venous return will reduce, then that will lead to reduce cardiac output. That's why the bowel movement should be there. And normalizing metabolic status. Metabolic status means mainly the electrolyte abnormality, hypokalemia, hypomagnesemia, that should be corrected. And adequate hemoglobin concentration. Again, hemoglobin, if the hemoglobin is less than 7, you have to give blood transfusion. So all these parameter, clinical condition you have to see before proceed to weaning. So the clinical criteria is resolution of the acute phase. And next thing you have to check whether the patient has a good cough reflex or not. So when patient is on endotracheal tube or patient is on tracheostomy and is ventilated, what we do, we just push the tracheostomy tube or endotracheal tube a little bit. So that will irritate the larynx and we can assess the cough. So this cough reflex is usually what we do is a subjective, but there are some instrument like peak cough flow meter, through that we can measure the cough reflex. That's a more objective one. Next thing is absence of excessive secretion. So this is very important. So if the patients, suppose I'll mostly describe the problems what happens with the neurological patients here. So suppose one patient with spinal cord injury, so high cervical level spinal cord injury, he is on ventilator. So there is always chance of increased secretion, because in all those patients with high cervical spinal cord injury, there will be parasympathetic hyperactivity. So vagus is so parasympathetic hyperactivity, that will increase the secretions. Is the audio is okay? Hello, the volume is very low.
No, sir, you're audible.
So someone is typing that volume is very low in the chat box.
No, sir, it's good.
Okay. So then I'll continue. So absence of excessive secretion. So parasympathetic activity is there in high cervical level spinal cord injury. So we have to control the secretion well. So one method is like frequent suction of the tube, it's the endotracheal tube, because if the tube is blocked, so already endotracheal tube has its own pressure. So airflow, there will be a pressure. We are pushing. If there is a blockage, so the pressure will be increased. So patients will need more inspiratory pressure. Already patients' muscles, inspiratory muscles are weak. We are giving through ventilator. So always we have to maintain the secretion is less. That we can give either we can give bronchodilator just to reduce any kind of bronchospasm. We can give anticholinergic like glycopyrrolate that comes as a nebulization also. So you can give glycopyrrolate nebs, salbutamol nebulization, and frequent suction. Next is the cardiovascular and hemodynamic stability. These are for any
So
patients.
Gaurav, is there any chance of improving the
Sir,
voice or volume? Is there any chance of improving voice or volume from your end? No.
my end. Okay, I'll see.
A lot of messages from other people also that voice, but for me looks okay. But people are
Okay,
telling
sir.
me.
I'll just give me 2 minutes. Sir. Hello.
Hello.
So is it better?
Is it now better? It's better
Now,
now.
now better. Okay. Actually, I was using headphone.
Yeah, it's better now.
Okay. So
Please,
whereas
yes, from here on. Okay.
yes. So I'll go to next. So now this is the ventilator criteria. So predictors of successful weaning. So patients is in ventilator. So I'll just give a brief about ventilation. What happens? Majority of the patients we give volume control ventilation. So volume control ventilation means we set the patient's tidal volume, minute volume, and the respiratory rate, and we allow the ventilator to decide about the inspiratory pressure and the expiratory pressure. So that is most of the setup. The volume control ventilation uses. There is a pressure support ventilation, but that needs more efficacy. That needs more expertise. So majority of the intensivists also in our hospital they use volume control ventilation. So in this all these parameters, what is you see in the slides, it can be measured. You can see from the monitor or from the ABG. So first is the minute ventilation. So what is minute ventilation? So basically, in one inspiration, whatever amount of air you are inspiring or expiring, that is the tidal volume. Tidal volume into respiratory rate, that is the minute ventilation. So respiratory rate in 1 minute. So if you multiply this, you will get the minute ventilation. So it should be less than 10 liter per minute. Vital capacity. So minute ventilation, you don't have to calculate. It is displayed in the monitor. So vital capacity per weight 10 ml per kg. If it is more than 10 ml kg, you can straight away go for the extubation vital capacity. Respiratory frequency or respiratory rate. Ideally, there should not be any tachypnea. So that less than 35 beats per minute. Tidal volume by weight. Again, the tidal volume by weight that you have to calculate more than 5 ml. Maximal inspiratory pressure. So the amount of pressure you are giving to make one alveoli open, to keep the alveoli open, that is the inspiratory pressure. That has to be minus 20, more than minus 25 centimeter water. And the most important criteria here, the next one, PaO2 by FiO2. So this is the arterial oxygen concentration by the fraction of inspired O2. So I'll just spend some time here. Arterial oxygen is what you get from the ABG. So this is the amount of oxygen which is present in your artery. So usually it is more than 60%. It is a value more than 60%. FiO2 is like you can calculate in our normal room air, or the FiO2 is 20%. So the oxygen concentration of room air is 20%, and rest of that is nitrogen. So in your ventilation, in your ventilation, if you put the probe to the oxygen connector, and you can change your FiO2, you can make it 50% FiO2. So FiO2 50% means the oxygen, whatever is coming through the pipe, your connector, that is 100%, and the ventilator is mixing free air and making it 50% concentration of oxygen. So FiO2, you have to calculate the amount of oxygen, inspired oxygen concentration is required to maintain your saturation level more than 90%. This is your FiO2. So if you put a saturation probe or through the ventilator, you can see what is your SpO2, and gradually you can change your FiO2 level. And if FiO2 low, then that is better, because the arterial PaO2 by FiO2 ratio, that has to be more than 200 or 300. If that's why, to make it more than 200 or 300, to make it higher, your FiO2 has to be lower. So when you are seeing any patients who is on ventilator, you can go and assess how much is the FiO2 is running. If FiO2 you see 60%, 80%, definitely you would say that these patients still will require to be in ventilation. It is not easy to wean off now. If you see that patient is maintaining his saturation and FiO2 is 30%, 20 to 30%, then you can say straight away that okay, next 2 to 3 days, he will be extubated. So that's why PO to FiO2 ratio is very important. This is also one of the diagnostic criteria when the patient is having ARDS. ARDS we frequently see for patient with traumatic brain injury also. So normally we define that PO2 by FiO2 ratio, if it is more less than 200, less than 300, then there is a ARDS. There is a mild, moderate, severe. It is less than 100, then we can say severe ARDS. Now the respiratory rate by tidal volume, the last point. So respiratory rate, that you can, that usually whatever respiratory rate 15 or 16 and tidal volume 500 ml, that you have to divide. And if the rate is less than 100, then he is successful for, he can be extubated. Now coming to the weaning procedure. So when you assess that the patient's clinical condition is good, patient is awake, alert, hemodynamic stable, there's no airway problems, then you can give some weaning trial. Weaning trial is actually called spontaneous breathing trial. Spontaneous breathing trial means you just extube, means patient is on endotracheal tube or tracheostomy tube, you disconnect the ventilator and allow the patient to breathe normally and see what are the parameters. So that can be done either giving the TPs. TPs is like a T-shaped one oxygen connector, that a pipe basically, that you can connect with the endotracheal tube or through the tracheostomy, and you can disconnect the ventilator. TPs is majorly used. Others method that can be used, pressure support ventilation or CPAP. Pressure support ventilation, here what we do, like just give a minimum inspiratory pressure just to reduce the work of breathing. And gradually, suppose you start with 15 centimeter of water, and gradually every 2 to 3 days you reduce by 2 or 3 centimeter of water. And if it is 4 to 5 centimeter off, then you can say that he can be given the TP trial or spontaneous breathing trial. The last one is a SIMB mode, or synchronized mandatory intermittent ventilation. Here, like you can preset the patients on, you can say that minimum means the mandatory minimum, there will be 4 or 5 breaths per minute patient has to take. So what happens, this is the most not recommended amount. So majority of the times we are expecting that patients will take 10 breath and minimum 10 breath, but patient may take more than that. So 10 breaths, 10 supports, 10 times the SIMB will give the inspiratory support. So sometimes what happened, whatever the SIMB gives, that will be the patient's maximum. So then SIMB is not working, it's basically a pressure support ventilation is going on. That's why this is not an ideal method of weaning. Majority of the setup, SIMB mode currently is obsolete. This is one important parameter I wanted to highlight. So it is a rapid shallow breathing index, or RSBI. So there is some calculator also. Today only I was searching. Some calculator is present in your mobile also. You can keep RSBI. So RSBI basically is the ratio of respiratory rate by tidal volume. If it is less than 100, then it's a very good predictor of that patients can be successfully weaned off from the ventilator. So you see, so patients, you have to calculate the patient's inspired or expired volume. So in one, so that is the tidal volume. and you have to calculate the respiratory rate. This is also there. Then you have to just divide respiratory rate divided by tidal volume. So that will, if it is less than 100 breaths per minute, then it is also a good criteria. So here I mentioned this. So I'll just go back. The last point you can see respiratory rate by tidal volume. So this is the less than 100. So this is the RSBI, or rapid shallow breathing index. So first I told the patient's TPs trial. For the spontaneous breathing trial, you can give TPs. Another one is a PSV, or positive or pressure support ventilation. Basically, this is a CPAP method. CPAP means continuous positive airway pressure. Means throughout the inspiration and expiration, there will be certain amount of pressure given just to for the respiration. So that will be maintained through inspiration or expiration. What is the role of pressure in the inspiration? Just to inflate the alveoli. And what happens during expiration, when the air is going out from your lungs, there is a high tendency that your alveoli can get collapsed. Alveoli can get collapsed. And if you remember in your physiology, the surroundings of alveolar epithelium is surrounded by the lined by the surfactant. So surfactant is a sticky material. So if they get collapsed during expiration, while you have to take the next inspiration, you have to give more pressure to just inflate the alveoli. So that's why, to prevent the collapse of the alveoli during expiration, you need minimum little bit of pressure during expiration. That is called PEEP. It's very important one criteria, PEEP, or positive end expiratory pressure. So positive end expiratory pressure is just a minimum amount of pressure which is present during the expiration to prevent the collapse of the alveoli. So PSB, or continuous positive air pressure, it is just giving to prevent the the collapse of the alveoli and maintain the oxygenation. So usually they start the PSB level at 5 to 15 centimeter water and gradually you can make the spontaneous. Your normal tidal volume is like 10 to 15 ml per kg. That is also set in the ventilator. And gradually you have to reduce the pressure by 3 to 6 centimeter of water until 5 centimeter of water is reached. So when you are in the HDU or ICU, if you see any patients who is giving spontaneous breathing trial and who is maintaining all the vital parameters and whose pressure support is 5 centimeter of water, then you can say he is ready for the extubation. So this is again one criteria when you are seeing the patients. So what is the pressure support? What is the minimum pressure? So if it is 10 to 15, then probably he will take few more days. You need more respiratory rehab during that time. But if he's coming gradually to 5 centimeter, 4 centimeter water, so he can be extubated. This is the SIMB weaning. So this is, I told, this is not recommended nowadays. I still put up. So this is like a minimum respiratory breathe you have to put. So minimum they can put 5 to 6 and gradually they reduce. So but it is not recommended. I'm not going into detail. Currently it is not, nowhere it is used. SIMB mode for weaning purpose. So there are three methods what I told. Either patients, you disconnect the ventilator and put a TPs, or put the patient in a pressure support mode or CPAP mode. SIMB not used. So now you are keeping the patient in a TPs for a 30 minutes period. Every day morning you do that. And you have to check the few parameters. When you call it that SBT, or spontaneous breathing time, whether this is failed or not. So do the ABG during that time. So ABG, partial pressure of oxygen in artery, if it is less than 60. This is the saturation. Second is, if the saturation is less than 90. Now, carbon dioxide level also, PaCO2, if it's more than 50. One thing I want to mention here. So in patients with neurological patients, PaCO2 is very important. So if carbon dioxide level increases in the blood, that has a direct effect on the intracranial pressure. So that can rise. So PaCO2 is very important parameter. So see, this PSA, to detect the PSA2, actually you have to do EBG. EBG usually in ICU patient they do twice only, in the morning and the evening. But and there is one more method, non-invasive method to calculate the PaCO2 is the EtCO2. So EtCO2 is the endotracheal tube carbon dioxide concentration. This is again, this is a small probe which is attached within the endotracheal tube with the ventilator, and in the ventilator you will see the EtCO2 graph, and from the EtCO2 graph you can calculate the PaCO2. So non-invasive method of PaCO2 used mostly all the neurological patients. And next is the pH. So if there is a acidosis, again you have to be careful. F by BT, that is the RSBI index or rapid shallow breathing index, which should be if it is more than 100, that means it is going to fail. Respiratory rate, it should be less than 35, and the heart rate, BP, systolic BP all should be normal, and cardiac rhythm also you have to see that time. So spontaneous breathing, not all the parameters you see every day. Usually the PaCO2, PA2, and PF ratio, and the RSBI or F by VT ratio. Now something, so when you call that weaning is success, weaning success is defined when ventilator is not there for 48 hours following the extubation. Now weaning in progress is an intermediate category. Then suppose every day you are giving the weaning trial, and one day you extubated and keep the patient on non-invasive ventilator. Non-invasive ventilator means either there is no endotracheal tube, but you give the patients through face mask, either CPAP or BiPAP. Weaning failure, then when the SBT failure, you have to re-intubate the patients. Then we call it the weaning is failed. This is a algorithm. I don't know how much clear is this. So first we have to see if the reason for ventilation is improved or resolved. So the underlying condition of the patients. Now we have to daily screening of respiratory function. Usually all these things, extubation trial or weaning trial is always given in the morning up when there are a lot of other physicians. You give a lot of other supports if you have to extubate, re-intubate the patient. So you have to see first the PF ratio, PaO2 by FiO2, that you can easily calculate, or just look at the FiO2 also. PF ratio has to be more than 200 or 300. If it is less than 200, then definitely this patient will take long time. And PWP, or I told positive in expiratory pressure. So positive PEEP, which is present during the expiration, that has to be minimum, so less than 5. And adequate cough, that can be assessed through any kind of swab stick. You just put into the nasopharyngeal wall, but otherwise just moving the tracheostomy tube. And the F by VT ratio, that is the RSVI index less than 100, and patient is not on any vasopressor or sedatives, so patient has to be alert. If all these things you assess, if you see that all parameters are not suitable, then you have to continue ventilation. Otherwise you can give spontaneous breathing trial, so 30 minutes trial with either you put the patient on TPs or the CPAP, or what we call it low level pressure support. If the patient is tolerating well, you can extubate the patients. So one thing, that how long will you give the patient spontaneous breathing trial? Means it usually they say that 30 minutes is enough. If the patient is able to tolerate 30 minutes of spontaneous breathing, that also suggests that this patient also will be able to tolerate 2 hours or more than 3 hours. So 30 minutes is sufficient time. After that, either you can extubate or you can re-intubate and can continue next day. You can give again trial. So if the patient is extubated, then post extubation respiratory failure, you have to assess again. Other you can give non-invasive ventilation for 1 to 2 hours. So non-invasive ventilation is mostly successful if those patients has any pulmonary problem. If the patient has any COPD or any heart failure due to pulmonary edema, those patients you can give BiPAP or CPAP as a non-invasive ventilation, and you can later on you can assess. So now coming to the weaning failure. I think I explained all this. So early signs of weaning failure, like blood gas analysis, all these parameters you can see, patient's vital signs, and respiratory parameters like tidal volume or respiratory rate. This I explained. Now, what are the conditions that may affect your weaning outcome? So when you can say that weaning is not going to be successful. So patient's conditions, like general condition, if the patients, most of the patients who is intubated and ventilated, there is high risk of hospital-acquired infection. So if the patient is on sepsis or not, cardiac problems, they can have any like any reason leading to cardiac failure. Patient's nutrition is again an important factor. Nutrition and electrolyte imbalance. All this, if these are electrolyte imbalance. So weaning failure usually happened either if there is a, so you give the patient a spontaneous breathing trial, patient is not able to tolerate, or there are signs of weaning failure. Then what are the things you will look for? One is if there is any airflow resistance. Airflow resistance, if there is a decreased compliance, decreased lung compliance, and respiratory muscle fatigue. So I'll just go one by one. First is increase of airflow resistance. So airflow resistance is like any patients whom you put the endotracheal tube or tracheostomy tube, told that there will be increase in the pressure in the lungs. So either this can be blocked. So they're starting from the ventilator to the alveoli. If there is any kind of blockage, the airflow resistance will increase. So you need to give more, patient has to be on more inspiratory pressure. The example, like an 8 mm endotracheal tube has a cross-section area of 50 millimeter square, which is slightly smaller than adult glottis, and the so narrowest part of the area. So it is always narrower than your normal glottis. So the inspiratory pressure has to be higher than a normal breathing. So to minimize the ET tube, larger size should be used when it is appropriate to the patient size. So measuring the ET tube size also important. So other strategy, how you can decrease the air resistance. So you have to always check whether there is any kinking of the endotracheal tube, where if there is any obstruction either by the secretion or any device in the ventilator, if there is any obstruction, suppose mist can get collected, mostly in the heat and moisture exchanger, that area, and endotracheal CO2 monitor probe that also used. So all these things can be managed if you do frequent suctioning and to remove the secretions, and bronchodilators, and as well as the anticholinergic like glycopyrrolate. Now coming to the second factor, what is the compliance of the lung? So compliance lung means our lung compliance is delta P by delta V. So with the pressure, the volume should not change much, and the vice versa. So what happens? Why the lung compliance can reduced if there is a collection of water? So that happens pulmonary edema or the air tension pneumothorax. If there is a collection of fluid, that is ARDS. Any kind of lung pathology that actually reduce the static compliance. And if there is an airway problem, that reduces the dynamic compliance. So you have to look whether these problems had occurred or not if the weaning is failed. Now coming to the respiratory muscle fatigue. So what are the causes of muscle fatigue? If there is a reduced lung compliance, suppose thoracic compliance, suppose the patients with high cervical spinal cord injury, all the muscles, accessory muscles, inspiratory muscles, diaphragm, all are like paralyzed. So their compliance will be poor. Now, if the patient is on mechanical ventilation, that means you are not using your muscles of inspiration or expiration. So that leads to atrophy of the muscles, mostly diaphragmatic atrophy. So for looking after the diaphragmatic atrophy, there is a new method now has come. We see that ultrasound, with the musculoskeletal ultrasound probe, we can assess the diaphragmatic thickness. That's a surrogate marker of inspiratory muscle weakness. So In GBS patient, actually, in our ICU, they assess the diaphragmatic thickness. And gradually, you can see that after giving respiratory rehab or respiratory inspiratory muscle training, your diaphragmatic thickness, so that is at least you prevent the atrophy of that or not. Next is the mechanical ventilation induce some oxidative stress because you are giving free oxygen. So oxygen related oxidative stress, insufficient nutrition, electrolyte imbalance, all this leads to respiratory muscle fatigue. So that's why respiratory muscle retraining of the atrophied muscle is important. So one way of improving the muscle or prevent the muscle atrophy is giving the patients on T2 trials. So allow the patient to breathe, allow the patient's respiratory muscles to work at least half an hour a day with the pressure support ventilation. So that increases your endurance of the diaphragm also. So this is the part so far I spoke about the weaning of endotracheal tube. So patients on ventilation, you expecting that this patients may not need long duration of ventilation. So at least within 4 to 5 days, if you expect that it can be weaned off, then this is the method. Gradually, you can take the patients away within 4 days. If the patient require, suppose more than 1 week of ventilation, usually they suggest for the early tracheostomy. So I'll just go for the patients who are on tracheostomy and how you plan to decannulate. So majority of the patients in HDU, what we get, they are just extubated for 2 to 3 days and who is on tracheostomy. So this is the part of the tracheostomy. So I don't know if I can get the marker. Okay, so you can see this is a Potex tracheostomy. There is no single lumen tube. There is the cuff. There is a balloon. So this is kept in the trachea and inflated. Balloon is inflated. So this is the tracheostomy tube with cuff. So there are some tracheostomy tube without cuff also. But in HDU, the patients, neurological patients who has poor cuff reflex, the high risk of aspiration, there is always tracheostomy tube is used with cuff, not without cuff. Mostly in the ENT setting, suppose the patient has a supraglottic growth, he has a laryngeal cancer. For them they use the uncuffed tracheostomy tube. So now, what are the predictive factors of successful decannulation in patients with trauma and patients who is in tracheostomy and brain injury? One important factor, this factor is a higher neurological status. So we all know if the patient GCS is better or CRS is better, then there is a more chance he can be decannulated. So, but there is a no consensus about which scale to be used for neurological status. A lot of studies they have used GCS. Some of them have used CRS or RLA. What we see, this is not always correct that low GCS patients cannot be decannulated. Lot of patients with hypoxic brain injury whose GCS we see hardly E4, that is spontaneous eye opening on tracheostomy, hardly M2 or M3. That patients also can be decannulated, but it takes long time. But it's not a very good indicator. Lesion localization. If the patient's stroke or stroke is tentorial, that means either in brainstem, that will take long time for decannulation or high chance of failure because the brainstem contains your respiratory and swallowing center. Type of lesions like we see that traumatic has a better chance than vascular than hypoxic. So any patient with brain injury, you can see that better chance of decannulation than infratentorial stroke than a hypoxic. So hypoxic brain injury has a high chance of decannulation failure. Cough reflex, again, very important factor. So if the patient has an effective cough, that means he has a good ability to control his secretion. And what is the quality of secretion, how thick is that, and how many times you have to suction the trachea. That is also important factor. Now coming to the effective swallowing. So if the swallowing is good, means then that patient's ability means their chance of aspiration is less. So that's why swallowing is also a factor for successful decannulation. But still, if some patients is on a rise tube, then also you can decannulate. Now, tracheal lesions. Tracheal lesions, like if the patient has any suprastomal lesions, so around the tracheostomy, there is a granulation tissue. That there is a chance that post decannulation they can have some kind of stridor. So that's why tracheal lesions can be assessed earlier. Pulmonary infection in a patient with pneumonia, sepsis, infection. Again, you have to delay the process of decannulation. Not absolutely contraindication, but you have to delay this. Early tracheostomy. So that is an important factor. We see that if the patients had a tracheostomy within 3 days to 4 days of mechanical ventilation, there is a better chance that you can decannulate them earlier. Last is the critical illness neuropathy or sympathetic hyperactivity. Again, that just delays the decannulation timing. Now coming to decannulation procedure. So how do you do decannulation? First, you have to give the cuff deflation trial. So here I told this. This is the patients with tracheostomy and cuff. So every day you have to just deflate the cuff and to see whether the patient is able to tolerate that. So what are the risks of cuff deflation? First, there is a chance of aspiration because that is one chance, and so that may increase the chance pneumonia. So cuff deflation trial you have to give. Before that, you have to make sure patient's ability to swallowing is better. And progressively deflation. So what we do, gradually reduce the size of the tube. So patients normally they will be either 7.5 or 8 size of the Protex tracheostomy type. Gradually, every 2 to 3 days, you can reduce by 0.5, 0.5. Gradually, once it becomes 6.5 or 6 size, that is very minimal diameter. That point, you can just corking or capping the tracheostomy. Just close the tracheostomy from outside and allow the patient to breathe through the mouth and nose. The alternate option is that you can give the patients one-way valve. One-way valve is the speaking valve. So this valve is attached to the outside of the tracheostomy tube. So that will allow the air to in, but you cannot exhale the air. So inspiration will occur through the tracheostomy tube, but expiration will be through the nasopharynx and the oropharynx. So again, that's why there is a movement of the vocal cord. And if you feel that patients have the ability to speak, so this is very important thing. You can give a trial with the speaking valve. But one thing you remember, when you give the speaking valve, you always should deflate. You must deflate the cuff, because if this cuff is there and you put the speaking valve, patient will not be expired. He will be able to inspire, but expiration will not happen because this cuff will. So the air has to go either through the tracheostomy or the surroundings of the tracheostomy. So surroundings of the tracheostomy tube inside the larynx is blocked because of the tube. So when you're giving speaking bulb, so speaking bulb must be there with the cuffless tube, or you have to deflate the cuff. Now, this is the downsizing. How will you downsize the tube? First, you can digitally occlude the tube and see if the patient is able to breathe and there is no drop in saturation, patient is not restless. Then you can gradually wind off from the same size tube. You don't have to downsize. But for the what we practice, we actually downsize the tube up to 6, and sometimes we do FOL and fees just to look for any supra subglottic stenosis. Fees means while putting the endoscope, or FOL, just give orally some coloring agent, and you can see whether there is any pulling of saliva or any kind of aspiration. Is like a direct visualization of the larynx. And gradually, then you can put downsize the tube, or alternately fenestrated tube or cuffless tube you can use. This is again a protocol. One study they have used this method for Debaraj et al. So what the if they consider the patients of tracheostomy, they went first for the office-based laryngoscopy. So office-based laryngoscopy means the OPD-based means the term is used means is a bedside laryngoscopy. Laryngoscopy is a just is a endoscope they can put through the nostril, they can put through the mouth, and you have to see few things. Then in signs of aspirations, whether if there is any abductor vocal cord palsy, or whether any stenosis, everything you can see. If this is there, then you have to. They went first for this is their protocol. So they went for flexible tracheostomy through the stoma. Through the tracheostomy stoma, they went up, and they have seen the subglottis, whether there is any suprastromal or tracheal lumen. If there is any obstruction, they went for a X-ray soft tissue neck, and if there is nothing, then this is block the tracheostomy tube for minimum 48 to 72 hours, and gradually decannulated the tube. Just on the other group T, Wang group, their protocol, like what they did first, they assess the patient's stability, and then they checked with the speaking valve or speaking valve whether the patient is able to tolerate or not. If the patient is tolerating well, there is no drooling, then cough strength is good. Then they straight decannulate. If the speaking valve patient is not able to tolerate, they did a upper airway endoscopy or that laryngoscopy, the same thing, and look for the upper airway edema, upper airway any granulation. So if there is an edema, they've given glucocorticoid trial, but that has a very poor evidence whether if there is a granulation, that needs intervention by the ENT. And after that, they again gave the speaking valve trial. The speaking valve, if they're able to tolerate, then they decannulate, otherwise long-term tracheostomy. Swallowing dysfunction actually doesn't have much problem while decannulation. Only there is a risk that after decannulation, if the patient swallowing is not good, then there is a chance of aspiration. Otherwise, swallowing is no direct hindrance for decannulation of the patients. I think that's all, sir.
Thank you, Dr.
If you have any doubts, please. I think there will be a lot of doubts.
Let's see what are the questions there in the chat box. First of all, thank you very much for concising the talk, which is very important one for the whenever we receive patient from any neuro issue or any critical care unit with tracheostomy tube. That's a very important thing. Let's see, is there any question in the chat box? I can see so many senior members are there in the list also. If any of our senior members can add to this regarding besides this presentation with their experience, please, they can give their comments or compliments.
Hi, sir.
Please, Dr.
Yes,
Rajendra.
yes, please.
Please.
Sir, hi, sir. I'm Dr. Rajendra Kumar from Hyderabad, sir.
Yes, sir. Yes, sir.
I have a few questions to you, sir. Actually, we have a lot of paraplegics and tetraplegics, sir. So actually, we have very difficult for them to remove the we extubate that tube, decannulate the tracheostomy tube, sir. Because whatever you have told for a normal person, you have told for a tetraplegic and a paraplegic, higher paraplegic, how should we manage, sir? Because one more thing is, if suppose tracheostomy is there, we can't do lung function test also, we can't do.
Yes, yes, sir. So suppose a higher level paraplegic who is on tracheostomy.
Yes, sir.
See, sir, few things. First of all, majority of the C3, C4 level of tracheostomy patients, they need ventilation.
Yes,
If
sir.
the patient has a partial innervation to diaphragm, that means little bit of inspiration is happening. There
Yes,
are
sir.
few problems that can occur. First is they have a inspiratory muscle weakness. So their work of breathing is more. So, and there is a poor cough reflex. So what we do, just manual assisted cough or vibration just to remove all the secretions, and you can teach the patients gradually the glossopharyngeal breathing. I know this is difficult for the patient also to learn, but that sometimes helps. And very good like spirometry you can give through the tracheostomy also sometimes. And otherwise you can keep the patients at night BiPAP mode. That also helps to reduce the hypercarbia or reduce the hypercarbia. And then gradually you can downsize and see if the patient is able to tolerate. And then first what you have to do, sir, inspiratory muscle training. That's the most important. Diaphragmatic muscle training. That can be done physically or some invasive trial like diaphragmatic pacing. That also can be done.
Okay, sir. Thank you, sir.
There are a few more questions in the chat box. Actually, can you explain a bit more about once again about FiO2, how to calculate that?
Yes, yes. So FiO2 is the fraction of inspired oxygen. So in our room air, oxygen content is 21%. Is it okay?
Yeah.
So 21% is the oxygen concentration, and rest majority more than 80% is 78% is the nitrogen. So this is so with 21% our so what we are inspiring in room air, all of us here. So with 21% our saturation is 100% or more than 95%. This is the normal scenario. In the patient with a ventilator, with the 21% oxygen, they sometimes not able to maintain their saturation. That's why you have to increase the oxygen concentration in their inspired air. So normally in the room air, the oxygen concentration is 21%. So when you are connecting through in the hospital, the lines through which the oxygen comes, there the oxygen concentration is 100%. So there normally when you give to the cannula, the oxygen comes through the water, water bubble, and that comes. Here it is not like that. So that water bubble, that bottle is not there when the patient is attached to the ventilator. The ventilator setup, the one probe is directly attached with the line, the oxygen line, from where you are seeing the 100% oxygen is coming. That 100% oxygen, ventilator has the ability that they mix with the room air and reduce the oxygen concentration. So this is the FiO2. So you can increase the FiO2 in that air 80%, 60%, 40%.
Is it has to be calculated? It is displayed in the monitor?
Sir, it is displayed in the monitor. So here the FiO2, the maximum you can do 100. The minimum is 21 in the ventilator. So that in what level we have to want to keep the FiO2 where your saturation is more than 95%. That will be patient's FiO2.
Okay.
Is it okay?
Yeah. One more question. Where you put a metal tracheostomy tube in the process?
So currently we hardly use mechanical the metal. I have seen only during my post-graduation days. So like when there is no particular condition, sir, where metal tracheostomy. Now everywhere it is the Potex. Maybe one thing is that metal tracheostomy, there is a obturator and there is a 2 lumens.
Yes.
So you can clean the inner lumens and can you can clean and reuse that. That may be one. So you can reuse this tracheostomy. Currently in all the hospitals in the private setup everywhere, sir, we use Potex. That is not reusable. So every 10-15 days you have to change the same size tracheostomy tube.
Abhishek, do you want to add anything? Is there an advantage of using metal tracheostomy tube?
Actually, sir, I've been using a metal tracheostomy tube because I deal with only poor and chronically ill patients. So those patients are years together on tracheostomy. So usually you put a double lumen tube, which is metal and with obturator. The basic reason is same. Easy, cheap, and usually we give two tubes to the patient, and they can actually boil alternately and keep it clean because Portex is too costly. Double lumen tube Portex is available in market and it's around 4,500 or 700 rupees, and it is only viable for few days. Then it gets infected. So that's a big problem. So for acute care setup, maybe it's okay, but it has its own disadvantage because metal is rigid and the person has to, the attendant has to learn. So my all patients in Bhubaneswar right now, they are on metal. Because they're long term, like the patient is on 6 months, 9 months on tracheostomy tube. Suppose there is a subglottic granuloma, we can't take out the tracheostomy anymore. Patient is walking, but still that patient is on tube. So because we can't, the ventilator passage may need a total RAFI or replacement of trachea. So this kind of situations we put it on metal tracheostomy. Most of the brain injuries, comas which I am seeing, and they are long term, so they all are put down the line on metal tracheostomy tube. If I can't get there, if I on when I do my either on ultrasound assessment or say endoscopic assessment, if their palsy is there, abductor palsies are there. So we have to maintain the tracheostomy tube, but maintaining them long term is pretty costly. Maybe for months together, it's pretty costly. Sometimes patients are in a minimally conscious state for months together. So you can't continue on Portex. So I was just wanted to know what is Dr. Sannyasi is doing at his place. I think he's in corporate, so they have a lot of money to manage it.
No.
Abhishek,
No,
do you reuse the metal tracheostomy tube?
Yeah, we give two sets of tube to the patient, and they can take out every outer lumen is taken out every 7 days, and inner can be taken out every day. So they keep clean. There is a cleaning protocol for tracheostomy tube, and they keep on cleaning and they boil it and again reinsert it. The infection rates are pretty low, and in Portex you can't do all this. So there is no cleaning and recycling thing. And tracheostomies, if they are metal, patient's relatives are quite confident in using and even steaming them or putting in pressure cooker and boiling them. So maintenance is
Moreover,
pretty easy.
this is, I think, very much helpful for a long-standing patient who are
Yes, sir.
long period.
Yeah, so we are in rehab, so we are doing more long-term acute care setup. Yes, when I was in ICU, then I used to do that. But nowadays, I see mostly those who have stroke and brain injury, they come to me after, say, at least 2 to 3 weeks after the stroke. So they don't come acute. So they come a bit, say, I would say, over a chronic side, they come to me where they are not able to decannulate it. Many of them, they come for decannulation to us. So we mainly use the ultrasound assessment, but many times they are not conscious, like their overall conscious state is a bit less. So when they are not conscious enough, and we are not sure because they occasionally show good effort of swallowing and talking, but occasionally they lose their consciousness because this is not that great. Especially posterior circulation strokes, we get a lot of trouble to manage them. And many a times even the GCS is quite low, but we are successfully able to decannulate for months and years together. So that helps because maintaining on Portex, it's a patient finds it very difficult to get discharged and go home with the Portex tube. That's what I am using currently. Maybe others can throw some light on that.
Thank you, Abhishek. Next question. Suppose somebody has come with a number 7 size of tracheostomy tube. Still you go for downgrade or you can straight away go for decannulation?
Sir, 7 is actually, you can directly go for decannulation. You have to assess the patients clinically. Suppose if the patients is in hypoxic brain injury patients, how is the patient's GCS? And the same patients, the other patients who is in, suppose patient had a lungs, currently one patient is admitted with us who has a LETM, longitudinal extensive transverse myelitis coming from the C4 to completely towards Kunas. He was given all this acute care, acute thing is over. He received rituximab and all. Patient is on tracheostomy. So at that point of time, tracheostomy 8 was put just to prevent any kind of aspiration. Currently, she is speaking. She is taking food. She is on cuffless tube. So this, if the patient is like that, who is on cough is deflated, patient swallowing is good, I would say that 7 you can directly cork the tracheostomy, block the tracheostomy tube, keep for 48 hours, and then you can directly decannulate. And suppose the patient general condition is traumatic brain injury or hypoxic, GCS is a little bit poor, there is a chance of aspiration, chance of pneumonia infection, then we go a little bit slow, reduce the size by 0.5, go up to 6. 6 is the lowest. You cannot go beyond that. So, and then you can give the blocking trial.
One more question is how to decannulate for a hypoxic ischemic encephalopathy patient?
See, this is the most difficult, and those patients takes long time to decannulate. In our experience, majority of the hypoxic brain injury, we don't try to decannulate them faster. At least give in the first 1 month, give them coma stimulation program, and then if they're responding something, continue, otherwise discharge them, send to home care. And then gradually, once their secretion, the most important part is the cough reflex and how are they managing the secretion. Because hypoxic brain injury, long term, their GCS will be always poor. There will be E4, VT, M2 or M3 maximum. So for them, you have to see the cough reflex and you have to see the secretion. If the secretion is less, you don't need frequent suctioning, and cough reflex is good, then you can give trial, like slowly you reduce, go up to 6, and then only block the tube for hypoxic injury.
Will TENS diaphragmatic stimulation improve to wean the mechanical ventilator or to CPAP? Can you go for stimulation of diaphragm with TENS?
There are theoretically, yeah, TENS helps. I have not used in my experience is not there TENS for, but yes, theoretically though that can be used.
Any experience about diaphragmatic external pacing? Is there any scope of that external pacing?
No,
of
so far
the
I have not. I do not have.
Any specific respiratory protocol for muscle fatigue conditions like myasthenia gravis?
Myasthenia patients, actually, it's mostly medical management, what I feel. Okay.
Any specific protocol need to be changed for the
No, sir,
regarding
it is same like see, this is myasthenia, again the muscle weakness.
muscle
It's the
weakness?
same protocol for the GV syndrome. Same protocol, like you have to give the inspiratory muscle training. So diaphragmatic strengthening, what we assess, and sometimes that ultrasound guided diaphragmatic thickness. That is as an outcome. So diaphragmatic strengthening protocol for them.
Okay, thank you very much. No more questions in the chat box. Already 9:10. So we have to wind up the session. Thank you very much, Dr. Gourav, for accepting our invitation with a very beautiful presentation and a very much interactive session with a lot of questions from the participants. Thank you very much. And I must thank all my friends of my department for supporting me organizing this webinar, and also thank to IAPMR for supporting, providing the Zoom platform for conducting this webinar. Thank you everybody for joining with us. We will again have one more webinar in the coming month. Till then, thank you very much.
Thank you so much. Thank you, everyone.
Good night, everyone.
Thank you, sir. Thank you, sir.